All right, I'm going to be presenting on LSVT Big. This is for PTA seminar for the Mustangs. I chose LSVT Big because I was able to do LSVT Big in my last 2 rotations. I found it to be very interesting. My grandmother has Parkinson's, and LSVT Big is a program designed to help patients with Parkinson's. So I'm excited to be able to share this with you today. LSVT, what does it stand for? Well, it stands for Lee Silverman Voice Treatment. There was a doctor named Dr. Ramij who had a patient that was unable to speak loudly. She had Parkinson's, and he was trying to figure out how he could get her to speak louder. Well, he designed a program, and this was all for speech therapy originally. He designed a program to have her speak louder than she thought she was speaking, so she'd be speaking loud. The reasoning behind it was that Dr. Ramij wanted to recalibrate her voice and decrease the mismatch of what's going on mentally to what's going on with her actual voice. So with recalibration and having her speak loud, he was able to have her speak a little bit more normal and louder than she normally would. Due to the success of LSVT Loud, Dr. Ramij thought he could transfer the program to physical therapy, which is why he designed LSVT Big and Loud. This is the big part. I'm going to be talking about LSVT Big today. LSVT Big is focused on recalibrating larger steps, cadence, and hip rotation with patients with Parkinson's. Again, recalibration is the key word today. Movement is big and loud. We want to decrease the mismatch between what's going on physically and what's going on mentally. Patients with Parkinson's think they're taking normal steps, but in reality, they're having a shuffling gait and they're taking small little steps. Repetition, repetition, repetition. What I mean by this is in order to recalibrate their steps and their speed, we need to have high reps and consistency. What I like about LSVT, it all comes back to, this kind of goes back to day 1 of our program and what the teachers always harped on. It all comes back to function. So when I think of vestibular deficit interventions that we use with patients, or we could even say with Parkinson's, we have them do things like get on the Bosu ball or put them on the Biodex balance system. I think those things are all great, and I'm not knocking on those. But what I like about LSVT Big is that it focuses on functional movements. So it has them stepping forward, stepping to the side, crossing midline, stepping backwards, and it involves actual balance activities. What I like about it is patients do not fall out of bed on a Bosu ball. They fall out of bed crossing midline and stepping backwards, stepping to the side. And that's what I like about LSVT, is that we attack the actual functional activities that is the true reason behind most elderly falls. Demonstration. So I'm going to demonstrate 1 round of LSVT Big for you guys today. Before I do that, I do want to show you an example of some research that has been done. So right here, this is a 3-month case study that was done. It's unpublished data, and I got it from lsvtbig.com. As you can see, the black is patients that had Parkinson's that went through the LSVT program, and in the gray, you can see the patients that had Parkinson's that went through Nordic tract balance systems and traditional vestibular balance activities. And as you can see, that LSVT Big has significant improvements in a faster cadence and larger steps. And this is one of many research and clinical studies that have been done on Parkinson's that proves that it does work. LSVT Big shows results. So I'm gonna hand over the camera. There we go, just hold it like that for me, down a little bit. Okay. Okay. So typically when we have patients that are going through the LSVT big, you're gonna have 3 chairs. One chair is for the pictures and directions for LSVT big. I'm gonna go ahead and put this right here. The other chair is for you as a therapist. Today I'm gonna be a therapist and I'm gonna talk to you like you're the patient. Okay, let's go ahead and get a quick, get right up here and let them see what's going on. So for this one, it's floor to ceiling. So go ahead and focus on me again. So what you're gonna do is you start big, you come out, down, up, and then you're gonna hold for 10 seconds. As a therapist, you could go behind the patient and give them tactile cues, pushing the shoulders back, have a big chest. You're gonna hold for 10 seconds, ask them to be big, 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 and then back down. That's the first one. Let's go ahead and take a look at the second one. It's right here. Okay. This one's called side to side. Focus on me. So this one, you're gonna start out. Now we're crossing midline. So we're gonna swing through. One important thing for this particular exercise is patients with Parkinson's are gonna do this the first time. We wanna give them external cues. So we could put something on the floor and say, I want you to step right here and point that toe towards that wall right there. You have to be direct. You don't want to tell them to think about doing something. Tell them what they're gonna do and they'll go out and do it. It makes it easier for their brain to process. Make it simple, make it loud. Exercise 3 is the forward step and reach. This one here. So you start right here. You're gonna come big and back. With this one, I'm gonna home right now, people are here. I'm not gonna stomp on the floor, but if you can have them stomp and you want them to be powerful, you want them to be big, and you want them to really just recalibrate the body and just go into a big movement. Alrighty, exercise 4, sideways step and reach. By the way, there's 8 total exercises. We're about halfway through. Start in neutral position here, and we're just gonna come out. And we're gonna reach and back. As a therapist, most of the time you're gonna be to the side of the patient and to the back of them. If they have balance deficits and you're worried about a fall, you could do this against a wall so that they only have one way to fall, and that's forward. But you definitely want to make sure, you can even use a gait belt. I've used a gait belt with a patient that had Parkinson's before as well. Exercise 5, we're going to do a backward step and reach. So right here, we're going to start with the stop sign. I always like to tell them, do the stop sign, and then we're just going to reach back. And then you raise your toes up so you're on your heels, and then come forward. Exercise 6. This is the rock forward and reach big. This one, we're not taking any steps. We're going to be staggered stance. For instance, I have my right leg out in front of me, and I'm going to bring my right arm up. And we're just gonna rock. You want them to do this with power, and you want them to be big. Exercise 7. Sideways rock and reach. Start big, twist big, and big. This one's a little bit difficult. A lot of times you'll show patients this and they're kind of like, what? So what you're doing is you're going to start in a wide stance. Take my right arm. We're going to bring it over to the left, and we're going to look behind us. and back. And the last one, your good old famous sit to stand. We've all done this one. So I'm gonna pop a squat right here, scoot to the edge of my chair. The only difference with this one is we're not just standing up. What you want the patient to do is bring their arms out in front of them, and they're gonna swing through. Good. All right. Thank you, photographer and videographer. It's my mother. Alrighty. So, I had a clinical instructor, or one of the physical therapists that I worked with his name was Chad, and he had a patient with Parkinson's. And when I was talking about LSVT big with him, he did not have a lot of experience with it. And he said, from my experience, when they leave the clinic, old habits return. And so that night I went home and I thought about what he was saying. And I think Chad made a great point, and I actually thanked him for bringing that up. Because if you have a patient that you prescribe LSVT big to, and they're not doing their part and doing their homework and doing daily movements big, then it's going to be very hard to have recalibration. You might have better results if you work on passive range of motion and you do the traditional vestibular deficit balance activities. If you're going to prescribe LSVT big or follow through with the plan of care that the PT has handed to you, you need to make sure that the patient understands what they're doing and that they need to be consistent in repetitions, repetitions, repetitions. Now when it comes to prescription, so this all comes from the LSVT big website. This is what they suggest for recalibration. So it's going to be 1 month program, 1 hour sessions, 4 sessions per week, 4 weeks in a row, with daily homework. And then after that 1 month program, they call it post LSVT. Now, Parkinson's is a lifetime disease that they're dealing with, so it's going to be every day for 10 to 15 minutes. Why do we need to recalibrate? Well, neuroplasticity, of course, the ability of the brain to form and reorganize synaptic connections. So let's get nerdy. Whoa, okay. I've got, this is the basal ganglia. We've got the direct pathway and the indirect pathway. I'm going to give the phone back to my professional videographer. Okay, go ahead and film me. We're gonna go, or film the board. So I've got a big old board right here. This is the basal ganglia pathways. Is the whole board clear? Yes? Okay, thank you. So when I talk about the basal ganglia pathway, I'm gonna talk, first I want you to assume that I'm talking about a healthy individual that has normal movement and no Parkinson's or no other pathology. So let's go ahead and start with the direct pathway. So what goes on if I want to move my leg? Well, the motor cortex is going to go straight to the striatum saying, I want to move my leg. The striatum is going to go pull from the substantia nigra. It's going to pull dopamine. Now, dopamine is the key player when it comes to movement because dopamine in the direct pathway is going to promote movement. So with dopamine, we can continue this cycle through the globus pallidus internal, through the thalamus, which is the ultimate gatekeeper for movement, and send the signal back to the motor cortex, which will result in me moving my leg. So dopamine is the key player and it's produced from the substantia nigra. Now simultaneously, while the direct pathway is having all these good, smooth synaptic connections and developing neuroplasticity, we've got the good old indirect pathway. So the indirect pathway is inhibiting movement, meaning the indirect pathway sends a signal from the motor cortex to the striatum saying, I don't want to move my leg. Now here's where it gets kind of tricky. In the indirect pathway, Dopamine is inhibiting the inhibitor. So in a healthy individual, we can go ahead and scratch off the indirect pathway, and that gives us the direct pathway. So this is stop, this is go. With dopamine, we're stopping the stop signals, which results in go. So with patients with Parkinson's, what we're dealing with is a 40 to 50% loss within the substantia nigra, which means we get less dopamine. So the result of that is we get that signal from the indirect pathway. We don't have dopamine to inhibit the inhibitor because we are losing dopamine with a substantia nigra with Parkinson's, which means now we have signals: stop, go, stop, go, stop, go. It's a freezing gait. It's small steps. All the things that are common with Parkinson's. This breaks it down to actually what's going on at the cellular level. Okay, thank you. All right. So what does this impact? Well, it impacts the anticipatory postural adjustment. It's when I actually consciously think about moving my leg and I go about and doing that and moving my leg. It's when a patient is made aware of a task to perform and the patient has to then perform that task. Why does this matter? Okay, so I want to shift your thinking here. So as we age, anticipatory postural adjustment response time is slowed. It's normal as we age, and when we get into the geriatric population, especially those with vestibular deficits and that are at an increased fall risk, they are losing cells within the basal ganglia and particularly in the substantia nigra, which results in less dopamine. Less dopamine, as we've discussed before, confuses the indirect and direct pathway, which will actually increase falls, especially in the geriatric population. So, my closing thought and clinical significance. I wanted to bring that up to you because when we think of LSVT big, therapists will typically think straight to Parkinson's. They want to think LSVT is just tied with Parkinson's. In my first clinical rotation, they really harped on the thought that no, LSVT big can be used for more than that. If results show that we have increased step length, faster cadence, and increased hip mobility, why don't we consider using LSVT big for the geriatric population that are at a high fall risk? They're losing cells in the substantia nigra, not at the same rate as those with Parkinson's, but it's still happening. I want you to consider that thought. Thank you for listening to my presentation. Here are my references, and I hope you guys have a great day.